All right, guys. Good morning, and welcome to another lecture that we have every second Tuesday of the month. And we are very fortunate today to have Dave Pedesma. But before we do so, I just have a couple announcements. As you guys all know, we are starting to digitally stream these lectures that will be online. There's a link that will be emailed to you guys if you're interested in the future to be able to do it. But we'll continue to have breakfast 6:30 to 7 and continue to provide these lectures. There are the capabilities, if you are watching them online, to send an email to ask questions. So I'm going to be in the back with my computer looking at any questions that come in and be sure to ask Dr. Pedesma of any questions. Because this is digitally being streamed, I would just ask if you have a question is to be sure to wait for the microphone just so everyone who's participating can hear your question, and we will try to come around with microphones as quick as possible. And we really look forward to our continued lectures throughout the year. We're coming up with a new curriculum for 2020, so if you guys have any ideas, suggestions, or talks you want to give, or ideas for us to give some talks, something you're interested in, please don't hesitate to reach out to me or Jared or Brandy or anyone that's involved and let us know. Today we're going to have Dr. Pedesma talk about hip pain in pediatrics. And Dr. Pedesma is not only a great friend of mine, but he started most of his career and grew up in Michigan, Michigan State, and then did all of his training at Wayne State. No.
University of Michigan, not Michigan State.
That's the same thing, though, isn't it?
Fighting words.
Michigan State, However, he has done, since he's been at Texas Scottish Rite, he is now the co-director of the Limb Lengthening and Deformity Center of Excellence here. But he also primarily does a lot of hip problems, complex hip problems in kids. He's been a member of the Anchor Group, which is a large academic group of surgeons across the country who look primarily at hip problems. And so he is well published in the hip. He's got tons and tons of articles about pediatric hip conditions. If you Google or PubMed his name, you're going to get overloaded with the amount of literature he's produced. So I think we're going to hear a great topic today from truly an expert in the field. So I'll hand the mic over to Dave Pedesma.
Okay, so today we're going to talk a little bit about hip pain in the pediatric and adolescent patient. I'm going to talk a little bit about the history and physical, and then we're going to go through several small vignettes, basically, and looking at a couple different topics, including slip capital femoral epiphysis, transient synovitis versus septic arthritis of the hip, and then some just a real quick review of apophyseal fractures around the hip and pelvis. At the same time, I'm going to also introduce some questions along the way, just to help you see if you know what you're talking about, and then I'll offer a little questions, so a review to make sure that what I've said is making sense to you. And we'll just take a little poll of the audience. The first thing we're going to talk about is a little true and false question here. Oh, let me add too, please. As I go through these little vignettes, do not hesitate to raise your hand and ask questions. I want to make sure that we have ample opportunity to do that, and we can definitely take a little time in between each of these sections. So true or false? A child or adolescent with primary hip problem always presents with hip pain in the limb. Those who believe that's true, please raise your hand. Those who think that's false, please raise your hand. Thank you. You are correct. That is not true. So what we want to talk about is, what is the chief complaint? Is it pain, limp, or decreased motion? Because some disorders can present without pain and only a limp. Where does it hurt? The history, as I frequently tell families and patients, the history, and this is true across medicine in general, you should be able to garner about 80% of what is wrong with the patient just by asking them what's wrong, including the chief complaint. Where does it hurt? It can be the hip. Is it the anterior hip? Is it lateral? Is it the groin? Is it the thigh? Is it knee pain? All of these things can help then start to isolate things. When does it hurt? Do they have episodic? Is it constant? Is it activity related? Is it at rest? Is it only at night? All of these things, again, are critical. What makes it worse? Is it weight bearing? Is it running? Specific activities, particularly sports related activities? Is it when they're squatting down to pick something up? Is it when they're if they're swimming, are they doing a flip turn and they start to have pain? Is it, when they're planting to either cut or to throw? Any of these things, can certainly help isolate where the problem is and what the problem is. And then what makes it better? Is it rest? Is it anti-inflammatories? Or is it just hurt all the time and it doesn't matter what they do, there's still a problem? The P in H&P, when we talk about history and physical, certainly can't be overlooked. It needs to be consistent and thorough, and it's important to try to develop a physical where you're doing the same thing over and in the same pattern, and that way it'll ingrain a consistent exam, and you try not to forget things. But we're going to start now. I'll have a little video here in just a second going through just a basic exam of the hip to help give you that idea. So visual inspection, cutaneous abnormalities on the skin, swelling, ecchymoses, looking at the joints. Are the joints swollen? Are joints painful? We look at the gait. Are they limping? Is it a Trendelenburg gait, meaning that they lean over that side when they're walking because of pain? Is it antalgic, where they don't want to place all of their weight on it and they walk very quickly on one side? Palpation along the anterior superior iliac spine, along the iliac crest, along the greater and lesser trochanters. And then range of motion, particularly looking for pain and looking for asymmetry in range of motion from side to side. And in addition, is there, you may have symmetric but limited range of motion, so is the range of motion not what you would expect? Strength, are we weak? And are they weak with pain? Are they weak without pain? Why are they weak? So this is just a few-minute video that goes through just a basic physical exam. Now, I usually start with the patient standing. Usually I've actually watched them walk at this point. Start with them standing to look at their lower extremity alignment, look at their knees. Do they have genu valgum? Do they have genu varum? Looking at their ankles. Do they have hindfoot varus or valgus? Here, the best way to look for a leg length difference is not with them laying down, it's with them standing. Actually, I'm going to back up here for just a second. So again, I can't stress enough, leg length difference needs to be standing with the patient's knees out straight, and you put your fingers on the top of the iliac crest and look to see if there's pelvic obliquity. Looking at them while they're laying down does not help because it's very easy to get abnormal lengths that way. You saw them squatting, looking for pain with squatting, looking for a limited range of motion, palpating the anterior superior iliac spine down along the rectus and the sartorius, up along the iliac crest, coming down through the abductors. Are the abductors themselves painful? Is the greater trochanter painful, particularly posteriorly where the abductors will insert? A lot of these kids will have abductor weakness. Then moving into the groin to see if do they have pain along the adductors, or particularly on the no problem. The psoas. Now looking at range of motion, I start with just gentle log rolling, one for pain and to see if there's range of motion difference from side to side. Again, trying to just get an idea of keeping my hand on the kneecap, so looking for just an orientation. Then again, anytime you're examining the hip and putting the hip through a range of motion, try to keep your hand on the pelvis, particularly ASIS, to see if the pelvis is moving. It'll give you an idea, because at some point you will come up to 90 or 100 degrees in this case, and then the pelvis starts to rock. And you want to know that because there are kids who will have range of motion issues that at 50, 60, 70 degrees of hip flexion, the pelvis will start to rock. And if you don't recognize that, you might think they have an unusual or a normal range of motion. Internal and external rotation, looking for pain with the rotation at the extremes. Simple abduction. Again, I've got my hand on the pelvis, making sure the pelvis is not moving. Because if there's a contracture or tightness, you can easily move the whole pelvis 50 or 60 degrees, but that may not actually represent the range of motion. Again, looking at adduction, bringing the hip up. This also can give you an idea if there's a hip flexion contracture by pulling the other hip up and holding it up and looking to see if the hip can still get into full extension. Flexion, abduction, external rotation. Eliciting pain, oftentimes can elicit, if they have SI problems, can elicit pain on the back as well. Straight leg raise, not only looking for range of motion for hamstring tightness, but also looking for strength. So we're looking at the resisted. Then place the patient in the lateral position. Again, palpating along the greater trochanter, the abductors, and then down over the IT band, down the lateral aspect of the femur. Again, it's very common, particularly in adolescents, to come with hip pain that will have abductor weakness and pain at the insertion site on the greater trochanter. And then after going through palpation, again, looking what we call the Ober sign, so extending the hip, allowing the knee to fall to the bed. The knee should easily fall to the bed. Oftentimes the knee will fall to the bed and then pop back up, and that demonstrates tightness in the IT band. I'll look at strength in the abductors, both with the knee flexed and the knee extended. So in this case, looking to see. And again, the important thing when looking at the abductors and you have them lateral is to have them roll forward and extend the hip. Otherwise, if you let them roll back, they start using their quads instead of their abductors. So got them leaning forward, extend the hip so they really focus the abductors. And again, resisted strength. Very common to have weakness associated with their hip pain. Put them prone, again, to look for symmetry in the range of motion. So this is internal rotation of the hip. And again, it's very easy if you're not holding the pelvis level to get an unusual or to get more motion than you think they actually have. So that's just, and there's other things you can do as well, looking at the alignment of the foot and the tibia by doing this, but this is just to focus on the hip itself. But again, this was just a little bit of a 5-minute video, and again, you can get that down in very few minutes, get a relatively thorough exam of the hip to give you an idea on pain, range of motion, and strength. So let's move on just to another true and false question. A groin pull or groin injury is a common adolescent injury that requires only rest, anti-inflammatory medications, and reassurance. Those who believe that is true. Those who believe it's false. Those who aren't sure. So yes, it is false, and we can't stress enough that children and adolescents do not get groin pulls. Recurrent limping and or pain, especially groin pain, unresolved with rest, likely has an underlying etiology. In fact, you need to prove that there's an underlying etiology or prove that there isn't an underlying etiology before you start to say that this is just a muscle issue. So this is a 13-year-old male who presents with a chief complaint of progressive right hip pain and knee pain for 2 months. And we're going to watch his gait here. And I'll give you a second to watch it, and then I'll tell you what we're looking for. So we're focusing on the right side. You notice that he does lean to that side a little bit. Doesn't like putting a little bit shorter gait on that side because his hip's hurting. You also notice that his right foot, you're going to see that in just a second, is externally rotated a little bit more than his left foot. He's a big adolescent. You can see he's got a little external rotation on both sides, but definitely a little bit more on the right side. So this is a typical kid that will get diagnosed potentially with a groin pull when you put his hip through a range of motion. He's got a painful range of motion. So what is the most likely diagnosis here? Is it a groin pull? Is it Blount's disease? Is it what we call idiopathic femoral retroversion, which makes the foot point out when you walk? Slip capital femoral epiphysis, or is this the result of a meniscal tear? I won't ask you to raise your hand, but I'll give you a second to think about that. But in this case, again, we know that kids don't get groin pulls. Blount's disease is a condition of the knee, abnormal of the growth plates around the knee. In this case, this is a slip capital femoral epiphysis. This is the perfect kid for a slip capital femoral epiphysis. Slips happen usually insidious in onset. That's the most common. Again, this child had 2 months of hip pain. It's not uncommon to have patients come in with 6, 7, 8, 9 months of hip pain that have gone either untreated or unrecognized. Local pain, so it's localized to the hip, though it can be knee pain, and they usually present with a limp. And oftentimes the first thing they notice is a limp and walking with their foot externally rotated. This picture of someone undergoing a knee arthroscopy. This also is unfortunately not an uncommon presentation in that they've had a knee MRI, and some have even had knee surgery because they've had continued knee pain, but someone failed to get an x-ray of the hip. because, again, referred pain to the knee is very, very common in this patient population. We see that these patients will, again, walk with a limp, with the foot externally rotated. When they're resting, that foot rests in more external rotation than normal. Limited range of motion of the hip, particularly internal rotation, and it's painful. Internal rotation is painful. That's the key finding, especially if you have someone who doesn't have obvious range of motion abnormalities. If they have pain with internal rotation, that should be a red light, a red flag in your mind. And then obligate external rotation with hip flexion, though may not always be present, is a very common finding. And this is an example of a patient with a slip capital femoral epiphysis. You can see he has very little, cannot internally rotate his hip. His knee is still resting in external rotation, and at rest, his foot rests more. And you can see with just gentle flexion of the hip, you see an obligate external rotation. So he has, 50 or 60 degrees of external rotation, but his foot cannot come to neutral. You can see there's automatically it externally rotates with hip flexion. So that's classic finding for a slip capital femoral epiphysis. As the head slips relative to the neck slips relative to the head, and the head wants to go a little posterior relative to the metaphysis, it causes that obligate external rotation with hip flexion. So this is the radiographic diagnosis of a slip, and again, this is important, but more important is what x-rays to get. And the most important thing you can do when an adolescent comes in with knee, thigh, or hip pain is to get an AP pelvis so you can see both hips, and to obtain a frog lateral of both hips. Yes, the natural thing is you have right hip pain, let's get an x-ray of the right hip. However, if you have an abnormal finding on the right hip, like a mild slip capital femoral epiphysis, 50% of the time you can see one on the contralateral side. So we want to make sure that both hips are checked. And in this case, you can see an AP pelvis. And what we talk about, oftentimes you'll see widening of the physis, which can be subtle, but you'll notice there's something called Klein's line. Now, if we draw a line that goes down the neck, and the left side here is the slip side, you can see that this is one continuous line along the femoral neck. Now, if you go to the normal side, this line along the neck will then come and go right through the femoral epiphysis, and some of the femoral epiphysis will be lateral to that line up the neck, where in this case there's no bone lateral to that line. So that's a subtle radiographic finding. And then the frog lateral clearly will show you where this is the epiphysis, this is the metaphysis, and we describe this as the ice cream falling off the ice cream cone, where this should really be more up here. This is an example of a patient who had months of hip pain, was seen in the emergency room. These x-rays were done. Now again, you have the AP of the hip, Klein's line, kind of subtle, may not, look, you could easily say that that's normal. But to a trained eye, there's definitely a slip here. This edge of the metaphysis really should be up over here. So there's a mild slip, which was not appreciated, nor do we have a picture of his contralateral hips. So he was told he had a groin pull, was sent home, came back several weeks, actually this was closer to 6 or 8 weeks later, and this was, continued to have hip pain, difficulty walking, and then these are what his x-rays looked like at that time. And yes, this is an extreme case, but this also is not, this is not a one-off. We unfortunately see too many kids like this. So he had massive, progression of his slip, and obviously had a big slip on his contralateral side too. So again, as a little review for slip capital femoral epiphysis, we've got an adolescent patient. If their obesity definitely plays into this, but they do not have to be obese to have slip capital femoral epiphysis. They will usually limp, their foot will be turned out, hip and knee pain, pain with and limited internal rotation of the hip. And that's something that needs immediate evaluation by orthopedics. Because and we're not going to get into the details of different kinds of slips, but you can have something very mild like that patient had on that x-ray, where it was not appreciated, and turn into something more severe. And that can change not only the natural history, it can be a life-changing event for the child if they develop avascular necrosis or an interruption of the blood supply to the ball, because it's gone from very mild to something very, very severe. So we want to address that, urgently. So just a little follow-up question. When examining the range of motion of the hip in the adolescent with a slip capital femoral epiphysis, the most common limitation will be with C, internal rotation. That's what you were thinking. After a thorough history and physical exam, initial imaging of the hip to confirm the diagnosis should be a... Anyone? Correct. C, Epipelvis, frog lateral. Oh, sorry, D, Epipelvis and frog lateral of both hips. Okay, so questions so far. We've gone through sort of a brief history and physical. We've gone through subcapital femoral epiphysis. If anyone has questions up to this point on these two little subjects, yes?
So with this type of patient, do you also see labral impingement or tears or something?
Yes, in case that wasn't, in case the question was, with these type of patients, assuming the slip capital femoral patients, can we see labral pathology and articular cartilage injury in these patients? And the answer is absolutely yes. There's different ways of grading slip capital femoral epiphysis. You can describe it as mild, moderate, and severe depending upon how much it has slipped relative to the neck. And there is one study that's demonstrated in the moderate to severe slips that over 80%, and there's 84-85% of patients that when you look inside their hip after a severe slip, they will have labral and cartilage injuries. So yes, it's definitely correlated with the more severe the slip, the more likely you are to have impingement. Meaning that for those who aren't clear, impingement meaning that when you're putting the hip through a range of motion, the ball should move smoothly in and out of the socket, but you can imagine if you normally have a hip that looks like this and it moves smoothly in and out of the socket, as soon as you've created you have a slip and you now have a prominent metaphysis, you're going to come up and hit up against the edge of the socket, and that creates cartilage injury, not only to the labrum but also to the cartilage inside the socket. So yes, that is a definite sequela. So yes, if you can catch them early, then it's much easier to deal with, and you potentially, prevent complications with that. Other questions? Anything online?
So the question was, if they have an injury based in a pediatric patient, if it's not a groin strain, what is it?
Well, that's a great question. And then there's multiple etiologies from a groin pain. So the key is, if you think if they're having groin pain, we need to sort out where that pain is coming from. To say that it's just a muscle injury and it's going to get better, that's where we start to run into problems. Slip capital femoral epiphysis can present with groin pain. In the adolescent, the athletic adolescent, again, what we call femoral acetabular impingement can present with groin pain. Hip dysplasia in the adolescent can present with groin pain. Injuries, like as we'll talk at the end, epiphyseal injuries, meaning avulsion injuries where you pull through the growth plate of some of the areas around the hip, could present with groin pain. And some of these things will present after a specific event. Some of them will be insidious in onset. The point being is that don't blow off groin pain in the sense that, you just kind of pulled a muscle, you're going to be okay. Because most of the time there is an underlying etiology that we want to evaluate and to address.
Many of us, whether we're in a training room or we're seeing a patient not with access to an x-ray, and I think we're all fearful to miss the skiffy, right, because of those x-rays that you just pointed out. If you had to tell us one thing to walk away from, to where if you see this in a kid with knee or hip pain, then you need to refer to get imaging relatively soon.
Pain with internal rotation. To me, that's the biggest thing. They're going to have limited internal range of motion, though limited internal range of motion does not mean that they have a slip, because in other conditions you can have limited internal rotation. But it's you can argue it's a constellation of limp, limited internal rotation, and pain with internal rotation, or they limp, walking with external rotation of their foot, limited internal rotation, and pain with internal rotation. Though, because I keep going back to pain with internal rotation, because you can have what we call a pre-slip, meaning that, or a very, very mild slip, which is very almost, where the x-rays essentially look normal, but if they have pain with internal rotation and they sort of fit this pattern of, the history and physical, then I certainly have treated kids in that condition where they have essentially normal range of motion, but they have pain with internal rotation. We then look closer to see if they have a slip, sometimes with MRI. Sometimes we just treat that because especially if they've had one on the other side. So I think I go back to this constellation of limp, external rotation, limited internal rotation, but really pain with internal rotation.
We have one more question.
Yes.
And when you say pain with internal rotation, do you like the log roll versus faders? Because I know with faders you get a lot of false positives because it can be painful in almost everybody. And so do you like the log roll? And then one other question about obesity. So you said that not every patient is obese, but I mean, I think what percentage would you say are not obese? Because I always learned, it's obesity is a big part of this. And so what percentage would you say are not obese?
Sure.
Or
Let me
is it a
address
majority?
let me address the first question, which is how to do I prefer flexion, hip flexion, and testing internal rotation with 90 degrees of hip flexion. And it doesn't have to be flexion adduction and internal rotation, because you're right, in conditions of impingement or other conditions, they can have pain with flexion adduction and internal rotation. But with a slip, just flexion and gentle internal rotation will elicit pain. So there doesn't have to be any significant pressure on it, because just that internal rotation is causing just enough micro motion through the growth plate that it's going to be painful. So you're right. I could make almost everyone here hurt if I do flexion, adduction, internal rotation hard enough. But in these kids, you don't have to force it. So I do prefer flexion for the internal rotation. You're right, and again, the majority of patients that we see are obese. But I would say anywhere probably 20 to 25% of the patients will not necessarily be obese, particularly in what we call an acute or an unstable slip capital femoral epiphysis, where they literally they've had some vague hip pain for a week or a couple months, and then they have an event where they step off a curb or they get hit or tackled or something, and then they have a big slip and a lot of pain. Those kids have been shown not to necessarily be obese patients. So it's something that should always be in the back of someone's mind.
One more question. So even in the mild scenario of the skip, would you still operate, or would you?
Yes. So any patient that has a slip capital femoral epiphysis gets a surgery, because we want to prevent that slip from progressing any farther. So we do what's called an in situ pinning. Without getting into the details of all that, we do what's called an in situ pinning, where we put a screw in through the neck into the head to keep that from slipping any farther. Yeah. Okay, so we will move on. So let's look at this patient. This is a 5-year-old who presents with a 24-hour history of left hip pain, inability to bear full weight. She's afebrile, has no other constitutional symptoms, otherwise healthy, except had an upper respiratory infection about 2 weeks ago. Exam demonstrates a near full range of motion of the hip, but is painful at the extremes of motion, both internal and external rotation. Labs, the CRP was mildly elevated, the ESR is mildly elevated, and the patient underwent a ultrasound-guided aspiration of the hip, because an ultrasound showed a hip effusion. So they aspirated the hip and found the white count to be about 10,000 white cells. The patient's likely diagnosis is it's either transient synovitis, septic arthritis, is this early Perthes disease, idiopathic juvenile arthritis, or is this a sign of osteomyelitis in the proximal femur? Anyone want to take a guess? So the answer is transient synovitis, and we're going to talk a little bit about transient synovitis, and then show what the difference between transient synovitis and septic arthritis might look like. So kids less than 3 and older than 10 do not get transient synovitis. It's very easy or very common that patients will be seen in the emergency room, or be seen and say, well, yeah, you've got some hip pain, you've been sick, but young kids and older kids generally do not get transient synovitis. 4 to 8 is really the sweet spot. 3 to 10 is sort of a broader area. Hip pain and fever and painful hip range of motion is septic arthritis until proven otherwise. So you really want to have a high index of suspicion. There's very few things in pediatric orthopedics that we consider emergencies or consider even urgencies, but an infection in the joint is one of them, and we want to have a high index of suspicion for that. So transient synovitis. Again, 3 to 9, 4 to 8, in that range is the sweet spot, and it's rarely outside that range. And if you think it is outside that range, then be skeptical that that's actually a problem. They're usually afebrile. The CRP and ESR, our inflammatory markers, usually are not significantly elevated. And if they are significantly elevated, you need to think in another direction. Hip aspirate, the white count is usually low. It's usually, less than 12,000 white cells. But it generally should be low. If we start to creep up, over 20 and particularly over 50, then we're definitely not looking at a transient synovitis. Usually ambulatory, are able to tolerate gentle passive range of motion, and it's usually except at the extremes of motion. So they won't necessarily have the same rigid hip that they will in a septic arthritis. And they usually respond quickly to ibuprofen. But again, so does early septic arthritis. So we don't use ibuprofen necessarily as a diagnostic tool, but it's more therapeutic because ibuprofen can mask fever and can mask an early septic arthritis. So we want to use our clinical and any of our laboratory values to help sort this out. So the appropriate initial treatment for a 5-year-old with transient synovitis, as I just mentioned, just as a little review, ibuprofen around the clock. We use it for 5 to 7 days around the clock. And then close clinical follow-up, because if it's truly transient synovitis, then the anti-inflammatory will decrease the inflammation. So transient synovitis from a pathologic standpoint is most commonly associated with upper respiratory infection. It's usually viral, and it gets into the bloodstream. It then gets into the synovium within the hip, and the synovium becomes inflamed and painful, and that then generates extra fluid in the hip that you see on the ultrasound, and then it generates a painful hip. So taking care of the synovitis with anti-inflammatories, getting that inflammation down, will improve their range of motion. The pain will go away. And usually over a course of 5 to 7 days around the clock, it'll go away. Now, if after 5 days of around the clock ibuprofen, the pain doesn't go away, the pain or the limited range of motion or the symptoms aren't resolving, then you really have to have in the back of your mind, is there something else going on here? So when we compare that to septic arthritis, the peak incidence is usually in the first 5 years. Staph aureus is usually is most common across all age groups. Newborns in the ICU, MRSA in Canada certainly can be an organism. Newborns who went home, Group B strep and Enterobacter. 6 months to 4 years of age fall into the King pneumococcus, and those are important to know because when we're looking for the organism, having the thought that Kingella can be a causative factor requires specific and special plating to get them to grow, and can be somewhat difficult to get them to grow. And now they have different techniques that you can use, PCR, to help diagnose those as well. There's a second peak in adolescence. And this is one of the points I want to hammer home is the septic arthritis in the adolescent. It doesn't act in the same way as it does in the infant or in the newborn or the toddler stage. It's more indolent in presentation, and it can be definitely more problematic. We can see it in the knee, the hip, the ankle, and the elbow. So it's not just septic arthritis of the hip. But the adolescent will generally present with a little bit longer drawn-out symptoms. They may not have the same rigid hip with a range of motion that you see in the infant, and can be somewhat hard, can be equally as hard to diagnose. They may not have the same response to a large fluid collection in the hip. It can definitely be somewhat difficult to diagnose. So septic arthritis often have fever. The CRP is usually going to be much more elevated than you would see in a transient synovitis. ESR is usually going to be significantly elevated, and the longer that they have it, the higher that these things are going to be, generally speaking, and they will appear sicker if this has been going on a while. The aspirate is usually going to be a much higher cell count. They're often extremely irritable with just gentle passive range of motion. Particularly in the small child, they're going to rest with their hip sort of flexed and externally rotated because that is a position of comfort because it maximizes the volume of the hip. So when you've got a big effusion of the hip, you want to you don't want to stress it, so they rest with external rotation and flexion. And these kids often don't want to ambulate because any sort of pressure is going to cause pain. Differential diagnosis is long. Obviously, transient synovitis. Juvenile arthritis is on this, but we have one of our rheumatologists in the room with us, and one of the things that they hammer home with us is that it's exceedingly rare that an arthritis will be identified primarily in the hip, and that it's usually going to be, there's going to be other, the hip is usually not the first place you'll see it, that there will be other signs and symptoms. Lyme disease, gonorrhea, particularly in the adolescent population. Obviously, you have to think about that. Post-streptococcal reactive arthritis, hemophilia, all of these things can look like septic arthritis. And then treatment, the most important thing is recognition. Once it's recognized, then it's our job to treat it. But if you recognize or are concerned about it, then we need to know about it so that we will obtain an aspiration, cell count, gram stain, cultures. These are all helpful for diagnostic. But it's really, if we have an infected hip, then irrigation and debridement. Washing the hip out is the most important, whether it's done open or whether it's done arthroscopically. We want to get that infection out of the hip because we know prolonged infection of the hip causes cartilage injury, and obviously we want to avoid that at all costs. And then we're going to treat them with appropriate antibiotics, which will be guided by the cultures. The other thing to remember is that if this has been going on long enough, that up to a third will have contiguous osteomyelitis, so osteomyelitis of the proximal femur, usually the femoral neck. It's not uncommon to develop osteomyelitis, again, blood-borne infection into the bone that then kind of simmers there and then can break out of the bone into the joint. So that's another way to get an infected hip, is to have that as well. Okay, so and again, beware of the adolescent, because this is an example of a 13-year-old female who had a minor sports injury and went to the ER complaining of hip pain. And it's, again, not unusual that infection starts after what's innocuous, sort of an innocuous injury. We see that in other joints. We see that, around the ankle where they have a little ankle sprain, or in the wrist where they fall and have a little wrist injury. But then the body is a setup for blood-borne infection at that point. So diagnosed with a hip sprain, and again, that's the danger of diagnosing someone with, oh, you've got a little groin pull or muscle pull, don't worry about this, and sent home on ibuprofen. 1 week later, was presented back to the emergency room in septic shock. She required vasopressors to keep her blood pressure up and keep her heart going. She was intubated. She was in the ICU, obviously, and developed massive infection throughout her hip, throughout her soft tissues, throughout her bones and the pelvis, and required multiple surgeries to get this. So this is an extreme case, but it always reminds us to have a high index of suspicion in the adolescent. And 7 surgeries later, her hip was bad enough that down the road, and this was quite a bit down the road, she required a total hip arthroplasty. So a 13-year-old who presented with sort of mild hip pain and didn't get a complete workup, and then this was a life-changing event. So this is what we want to avoid. So let's take another break for questions if anyone has questions on the transient synovitis versus septic arthritis part of this. So the question was, what percentage of the time is it just the hip? That's a good question, and I'll be honest with you, I don't have an answer as far as a percentage. We certainly, in the neonatal, or excuse me, in the pediatric population, kind of under age of 5, the hip is, in my experience, more common than what we see as far as knee, ankle, elbow. But certainly, you can have it in any of the joints. There was another question. Yes, sir.
On that prior case that you just showed, did she present with fever?
At that time, she did not have, I don't think she presented with fever. She then developed fever, I think, subsequent to that.
Because I was thinking, when you're in an ER and you have a kid show up like that, you're not automatically going to get a CRP or an ESR on them, especially if they aren't running fever. What else could they have done that would have caught it earlier?
Well, part of it is, the devil's in the details,
yeah.
And whether she, had a high fever or low-grade fever at that time, I can't tell you with certainty. I don't think they presented with a fever. Then the question, or the importance then is the close follow-up. And, if you develop fever, if you start to have more pain, if the ibuprofen isn't working, if anything's getting worse, then you need to return right away. It's at least keeping it in the back of your mind that, if any of these bad things do happen, then we need to see you right away. Because as I mentioned, these are, we see patients in clinic all the time with sort of vague complaints of hip pain, knee pain, leg pain. And I tell families all the time, I don't see anything today. Here are the 3 things that, I consider emergencies or urgencies in my practice. Infection is one of them. So if you start to have any of these signs or symptoms, you need to call and return right away. And unfortunately, we do see patients quite a bit who present in this condition, with severe infection that have been kind of sitting at home for 5 or 6 days, and the pain's been getting worse. They've been having fevers, and I'm not blaming the families in any way, but they need that sort of reinforcement that if any of these things develop, we need to see you right away so we can prevent that from happening. Any other questions? Okay. So this is sort of our last vignette. This is a 14-year-old male, 24-hour history of anterior right hip pain after feeling a pop while sprinting at track practice. Able to bear weight, but it was able to bear weight with pain and limp. No fever. Exam revealed a painful passive range of motion, especially with full hip flexion and hyperextension of the hip. And the X-ray that he presented with, you can see on the screen. I'll give you a chance to look at that. So the question is, what is the diagnosis? Is it an iliac wing fracture? Is it an anterior superior iliac spine fracture? Is it a femoral neck fracture, slip capital femoral epiphysis, or a femoral head fracture? Anyone? It is an anterior superior iliac spine fracture. So what we're looking at is the anterior superior iliac spine is right here. And then this is an avulsion fracture of the anterior superior iliac spine. And this mechanism is super common. So these are apophyseal fractures. When we talk about avulsion fractures of the pelvis, we're talking about areas where there's an underlying growth plate. And these are the most common, these 4 areas are the most common. Anterior superior iliac spine, anterior inferior iliac spine, lesser trochanter, and the ischium. Now, the greater trochanter certainly can also happen, but that's extremely rare. The anterior superior iliac spine is probably the most common that we see, followed by the anterior inferior and the ischial spine. Now, what's unique to all of these is that you have muscles that are attaching to each of those areas. Underlying those muscle attachments is a growth plate. And the growth plate, as I described to parents, is just basically, it's just gristle. It's just cartilage, it's just gristle. And these are adolescents who have who are doing sports that require a great deal of cutting, sprinting, pushing off, and they're getting a big eccentric contracture, or they're getting a resisted concentric contracture of their muscles, and it's just overpowering the growth plate, and it just pulls that piece of bone away from the pelvis. These are acute, they're athletic injuries. Boys are more common than girls. It's right into that 12 to 14-year-old age range is far and away the most common as they're starting to mature. And again, it's this powerful muscle contraction. And again, the ASIS has the sartorius attached to it, the rectus and the AIS, and the hamstrings and the adductors on the ischial tuberosity. The vignette describes the most common situation. It's a sprinter, it's a basketball player, it's someone who's cutting and pushing off, or they're getting out of the starting blocks, or they're going to hurdle and they're pushing off. All of these things create big muscle contractures, and they'll feel a pop. They'll feel a pop. Oftentimes the person standing next to them will hear a pop, and they'll have immediate pain, but they will be able to get up and limp around, but it's hard to get back. So adolescent athlete, sudden strenuous activity, sharp pain, audible pop. It's very localized. And then obviously passive stretch, really, and just simple palpation there and it's always going to be typically very localized pain. If they'll come in saying my hip hurts, but you ask them where does it hurt, they're going to point right where it hurts, and it's usually going to be a little swollen and painful, and if you push there, it's going to hurt. And the good thing is that usually with rest, generally 6 weeks of rest, and then working on, we have a rehab protocol for stretching and strengthening through this 6-week period, it's going to heal and they're going to get back to their regular activities. But it does require a period of rest. And this is an example of a healed anterior inferior iliac spine avulsion. Conservative rest, NSAIDs, activity modifications. It's extremely rare that we have to operate on these, but there's no question that patients, the most common being the ischial spine, that if this, you can oftentimes get enough displacement, and then when they return to activities, it's just not healing, and it can become painful. They can have weakness in their hamstrings, and that's the most common that will be treated either acutely or most commonly in our situation, you'll see it chronic non-union of the ischium that will require treatment. So the most appropriate initial treatment for this injury, as we just talked about, is ibuprofen, crutches as needed, activity restrictions. Then we'll also include physical therapy to work on stretching and strengthening as this heals. Questions about apophyseal fractures? Dr. Ellis, were there any questions?
There are no e-moderated questions, but I have a question for you.
Certainly.
With a suspected apophyseal injury upon an acute presentation of a young athlete, do you think x-rays are necessary?
No. The short answer is I don't think you have to have them, especially if you have the classic findings of I was running or sprinting or cutting, I heard a pop, and it hurts right here, and I've got inflammation. Now, is it possible that you could have there could be other things? Yes, and I think, if you told me, do you have to have one? No. Do I want to get one? Yes, because one, I want to confirm what my physical exams, and I'll be honest with you, oftentimes from a parental and family, sort of reassurance and confidence to say, all right, here's what you did, here's what you're looking at on the x-ray, we know that this isn't going to be a problem, we need to let this heal. Now, what I frequently don't do is I frequently don't get a follow-up x-ray at 6 weeks unless the family is concerned enough that they want to see that it's healed and they're back. But if they're asymptomatic at that time, I don't think you necessarily have to have a follow-up x-ray unless they're symptomatic.
Gotcha. A little bit of a second part question is, I think that as you alluded to in the beginning part of your talk, that this is kind of a bony corollary to a soft tissue problem that occurs in more mature athletes. And so from a rehab and treatment perspective, do you think that they heal equivalent to a soft tissue injury, and would the therapy on the back end be about the same, or do you have them change it up because it is a bony problem?
I think the bony problem heals better than the soft tissue problem because there was a time in my practice where we didn't really spend a lot of time on rehabbing these kids until after their 6 weeks of rest, and now we tend to rehab them a little bit more aggressively during their 6 weeks of rest. I think any time, and I always will sort of joke with families that have ankle fractures, I think having an ankle fracture is more predictable than having a bad ankle sprain. And it goes to the reproducibility of the bone healing or the predictability of the bone healing. So I think an avulsion fracture versus a true tendon injury or whether muscle pull, muscle strain, muscle tear heal in my opinion, heal less predictably than the actual bony problem. I think you're better off pulling off that bone heals, and then rehab the strength, and I think that's better than not having the bony injury. Other questions? That's sort of the last vignette we have. Yes, sir.
So just about the leg length discrepancy topic that you addressed at the beginning. When do you consider leg length discrepancies to be a significant factor in hip pain? And what imaging procedures do you use to determine whether there is a true anatomical difference?
That's a great question. So we know that based on data that was studies that were done at this institution using gait analysis, basically we suggest that anything under 2 centimeters or less, we essentially ignore from a leg length difference. When we start to get over 2 centimeters or 2.5 centimeters, then there are things that we can do while the kids are still growing from a treatment perspective to equalize those leg lengths. Now, all of that being said, we know that based on gait studies, that when you get over 5% of the leg length difference, so 5% being, let's say that we know that the average adult has a leg length of about 80 centimeters. So 5% of 80 centimeters is 4 centimeters. So we know that for the average adult, when you get above 4 centimeters of leg length difference, you can then start to see changes in their gait patterns and see changes in the hip, the knee, the back. And over the long run, obviously that could cause problems. It's not to say that we don't have patients with 5, 6 centimeters leg length differences that don't ever want anything done for their leg and are happy using different things to help equalize that leg length. But if you ask where do we start to get concerned, it's over 5% of the overall leg length. Anything under 2 centimeters, we ignore. There's millions of people walking around with 2 centimeters or less of leg length difference that will have zero impact on their ability to participate in sports or have any long-term outcome on their ankles, hip, knees, back. The best way to look at their leg lengths, or what we most commonly do, is we get a standing AP of their bilateral lower extremities. We have a imaging technique called EOS, which is a very low dose image of that you can image the bilateral lower extremities and get an actual length measurement of both extremities. There's other techniques you can use as far as what we call scanograms, but from the lowest dosing of radiation exposure to get the measurements, the EOS, a standing X-ray of both lower extremities. Now, the caveat to that is we don't like to do standing films in kids who have deformities. So if you're talking about the average, athletic kid who has full range of motion in their joints and can stand with their knees straight, then that's the ideal way. And when we get kids who have flexion contractures or deformity, then standing films aren't often the best way because you can't take into account that deformity when they're standing. Other questions? Okay, well, I thank you for your time and be happy to answer any questions offline should you have them. I'd like to thank those who are watching online for the streaming. We appreciate your time today.
Thanks.